Welcome, everyone. We will start the broadcast in 2 minutes. Welcome, everyone. We will begin in 1 minute. So hello, everyone, and welcome to the LLSC's National Leukemia Conference. Though we have offered this event for 3 years now, this year is the first of its kind as we are coming together virtually. Throughout the week, we shared educational tools on leukemia as well as stories of hope. This will be the final presentation of our 3-day event. If you've missed any of the previous presentations, do not worry. All our conferences are recorded and will be made available for viewing on our website. In today's presentation, we will learn more on treatment options and what you can do to minimize the impact and side effects of cancer treatment for CLL. Let me introduce myself. My name is Sonia Muto. I'm the Community Program Coordinator at the Leukemia and Lymphoma Society of Canada. I will be the moderator of this online event. Welcome to everyone. The presentation will last approximately 60 minutes, which will include a question and answer period. Since there are many of you, we invite you to type your questions and comments in the question box of your GoToWebinar panel throughout the presentation. An LLSC staff member will be monitoring to answer any technical or program-related questions. We will read some of the questions out loud at the end of the presentation during the question and answer period. Due to the number of questions, we may not be able to answer all of those questions posted, but we will be sure to get you a reply outside of the presentation if your question remains unanswered. The conference, again, will be recorded, so therefore you can listen to it again on our website, and we will send you an email when everything's available. Before we begin our main presentation, I would like to share with you our mission and highlight some of the resources that might be helpful for you or someone you may know. At the LLSC, our mission is to cure blood cancers and improve the quality of life of those affected by blood cancer and their families. Ultimately, we are here to serve you. We offer support and guidance to people affected by a blood cancer along the way. Do not hesitate to contact the Community Services Manager in your area to learn more about how we can help you. We offer a variety of educational resources and support services to help those affected by a blood cancer. On our website, you can access free information booklets and fact sheets about blood cancers, treatments, and psychosocial aspects of your journey. On our website, you will also find recordings of all our past webcasts and announcements on any upcoming webcasts. Just change those slides. There you go. Too far. Okay. Sorry about that. We also have a series of educational videos on CLL. For example, what is CLL? What is watch and wait? Treatment options, and many more. Visit our website at bloodcancers.ca to view those. We invite you to subscribe and listen to our podcast series, The Blood Cancer Experience, to learn more about treatments and research from experts, and to hear stories directly from people affected by blood cancer. Our podcasts are available on Spotify, Apple Podcasts, and anywhere you enjoy listening to your favorite podcasts. Our peer support program is a support service that matches people affected by blood cancers, caregivers, and their families with trained volunteers who have been touched firsthand by a blood cancer and share similar experiences. It can be a supportive program, especially during the pandemic, to counter the effects of isolation. While 2020 is not a year filled with many highlights and things to share, we are proud to share that in June 2020, we launched Your Life After Cancer program. We know that every cancer experience is unique and that every step has a deeply personal meaning. This program offers tools and resources you may need to help you move forward after your blood cancer experience. Visit yourlifeaftercancer.ca to view our new fact sheets on important topics such as fatigue, cognitive issues, and how to support a loved one. You will also find webcasts and podcast recordings along with inspiring stories from survivors. And finally, we would like to introduce our CLL Information and Support Facebook group. It is a space designed for those living with CLL to share stories, to share experiences with one another, to ask questions, and to support one another. So it is now time to introduce our speaker, Dr. Vighnesh Bharath. Dr. Bharath is a hematologist oncologist at Humber River Hospital in Toronto, Ontario. He completed his medical school training at Queen's University in Kingston and his internal medicine and hematology training at Western University in London, Ontario. He practices both benign and malignant hematology, with his primary interest being thrombosis and myeloproliferative disease patients. Outside of his clinic work, he is actively involved in medical student teaching and research, and currently acts as the education coordinator for the oncology department at Humber. He sits on various committees, including the Transfusion Committee and Anticoagulation Committee, and holds a master's certificate in healthcare leadership from York University. Thank you for being here, Dr. Bharath. Over to you.
All right, thank you so much, everyone. Thanks, Sonia, for the lovely introduction. I'm Vighnesh Bharath, and like we just heard, I'm at Humber River Hospital with hematology. So it's my pleasure to be here today. Hopefully, I regret not being able to see everyone in person, but hopefully you'll learn a little bit more about CLL from the talk today virtually. So the goal of today really is to give you an overview of CLL. We'll focus a bit more on the treatment aspect of things as well, but I'm going to give you a bit of an overview of this malignancy and what you can kind of expect from a patient perspective with this. So I think it's always nice. So patient education is such a big, important piece in any kind of cancer diagnosis or treatment. And it's really important for you to kind of know what you have and what questions to ask, et cetera. So on that theme, I thought we'd start with a few questions just to kind of see where you're at so far. So I think we're going to get some help with a poll here, and we'll see what you all think for the next few questions. So here's the first one. So we'll give you about 30 seconds or so, and then we'll maybe look at the answers. Excellent. So most people seem to have picked B. All CLL patients are treated with chemo right away as an answer that's false. And we'll come back to this in the end, but great. So let's move on to the next question here. So here's number 2 as well, A to E. And if you could do the poll again, we'll see where people are at. So what test is the most important for diagnosis of CLL? Sorry, I should have read the other one too, but for those who needed a quick. readout. There it is. All right, awesome. So CBC and flow cytometry, excellent. All right, looks like a really smart group here. Okay, go to the next one. All right, number 3. Which of the following is not a treatment option for CLL in 2020? So as of right now. All right, hormone therapy is not an option. Okay, I think my job here is done. Everyone's too good. All right, so let's go to the next one. I think there's maybe 1 or 2 more here. Question 4. Which of the following is a biologic therapy used in CLL? Ibrutinib, excellent. Okay, we have some very involved and active patients here, which is great. You know a lot about your care, which is very important. Okay, and I think this is the last one, just on those same lines. The ibrutinib. So here's the question 5. Which of the following is a known side effect of ibrutinib? Okay, perfect. So all of the above. So we will come back to these questions at the end, but excellent job with those. So the last one here is really just a poll, so I can get an idea where everyone is at or where you're from today. So we can go ahead with this one. So as an attendee today, what is your role? Excellent. So most people, 70% are patients with CLL, which is excellent. That's what I was
just holding this.
All right. Okay, everything okay? All right. Okay, so
Sorry
most
about
people,
that. Yeah, I took care of that.
okay, no worries. Sounds good. Thank you. Sorry about that. Okay, so so as I was saying, most people here are patients with CLL, which is excellent because I was really hoping that I can cater to people like yourselves and kind of talk about the disease and help you get more educated about it. So I'm very happy that a lot of people are here today to learn about it. I think the education piece is very important in your diagnosis. So thanks for being here. So that's it for the questions. So we'll go on to kind of the overview. So as I said, we'll do a brief overview of CLL. We'll go over some background, the mechanism of the disease, symptoms and tests, staging, prognosis, and then the big when to treat, a treatment overview, side effects, how to check for response, and then finally complications of CLL, and then a few points on drug coverage and emerging treatments. So It is a lot of information, but I've tried to cater to mostly the patient with CLL, so hopefully it'll be helpful and simplified for you. All right, so to get started, so the main thing with any blood disorder is how blood is made and what part of that pathway is affected, right? So if you, I don't know if any of you are or have a science background, but if you do, you might know that blood is made in the bone marrow, which is usually located in the hip bone. That's where most of the bone marrow is, which is why when you have a bone marrow biopsy, they put a needle in there and take it out of there. So that's where the blood is made, and you have these things called hematopoietic stem cells. So stem cells are these really amazing sort of versatile cells that can turn into really any other type of cell. So they divide and differentiate into all your blood cells. So they're like the mother of all cells. So they turn into red blood cells, they turn into white blood cells, and they turn into platelets. And among the white blood cells, you have a variety of white blood cells, so neutrophils, monocytes, et cetera, et cetera. Lymphocytes are one of those white blood cells, and that's the cell that turns into cancer in CLL. So in CLL, you have chronic lymphocytic leukemia, which means that the lymphocytes turn cancerous, and that's what's causing the disease. So those are the cells in question here. So it's a cancer of lymphocytes, as I talked about. It's the most common lymphoid cancer. And when I say lymphoid, it refers to lymphocytes. It's about 5 per 100,000 people per year. So it's pretty common when you think about it in that respect. It's more likely in the elderly. The median age is about 70 to 72. I did consider in the poll asking about your ages as well, but I wasn't sure if everyone would want to divulge that. But it would be interesting to see, because most people with CLL are a bit elderly, elder than some of the other cancers, such as something like Hodgkin's lymphoma tends to be younger. So it's interesting to see that. It's usually male compared to female. It's about 2 to 1. And we seem to see it more in Northern European populations. So that doesn't mean it doesn't happen in others, but it's just more common. The actual cause of CLL, like many other blood cancers, is actually not known. We think there might be something to do with potentially exposures in the environment, maybe viruses, maybe something genetic, like we don't really know, but it tends to be just out of the blue, de novo, which means it just happens in you all of a sudden. It's not usually inherited, and that's all we really know. The treatment really has advanced quite a bit. 10 years ago, people with CLL got chemo. It was very toxic. Unfortunately, they died younger, and it wasn't a great disease to have. But now there's a lot of other treatments, and a lot of them are actually not even chemotherapy. They're biologic therapies, which is excellent. So how does CLL actually work? So you recall I told you that these come from lymphocytes. That's what causes CLL. There's B lymphocytes and there are T lymphocytes. B as in Bob, T as in Tom, B and T. Most CLL patients, the cancer starts from B lymphocytes. So just a little tidbit to know. The CLL can be in your blood, it can be in your bone marrow, it can be in your spleen, which is in your abdomen, or it can be in your lymph nodes. So lymph nodes are these little organs, almost little nodes all throughout your body. The main place that you see lymph nodes are the neck, the groin, the armpit, or axilla, we call it. And these lymph nodes all connect like a chain, and they help to get rid of toxins from your body. So lymphoma or leukemia, CLL, can be in these lymph nodes. One thing to mention is CLL has sort of a sister disease or a counterpart. It's called small lymphocytic lymphoma. So if CLL is in the blood or the bone marrow, we call it CLL. But if it's also in the lymph nodes, and specifically if it's only in the lymph nodes, then we call it SLL, or small lymphocytic lymphoma. If it's in both, we call it CLL/SLL or CLL, doesn't really matter. So it's more of a technical thing, but there is another name for it, sort of. And ultimately, it causes problems with your organs and your blood cells, because there's cancer cells there that shouldn't be there, and that causes problems. Symptoms. So the most common symptom in CLL, believe it or not, is nothing. Most people with CLL have no symptoms, they feel fine, which is good because it means that you're coping well, your disease is not active, but it can also be a bad thing because it's difficult to catch unless you have blood work done. So if you do have symptoms, it's usually constitutional symptoms, or B symptoms we call them. I don't know why they're called B symptoms and not A or C symptoms. It's just, I think that was just how they were named. But B symptoms refers to fevers, weight loss, and night sweats, those three things. So lumps and bumps are also common. So those lymph nodes that I mentioned in your neck or your arm or your groin, they can swell when the lymphocytes that are cancerous start growing in them. And when they swell up, it's like a lump or a bump, and that's common. Abdominal pain or feeling full really quickly. So you eat lunch and then you feel, boy, I'm really full already, and you've only eaten a very small lunch. That's maybe because you have a big spleen, and that can happen in CLL. And then you can get symptoms of low blood count. So things like infections, feeling tired, bleeding. So those are some of the common symptoms. Keep in mind, a lot of these are non-specific, which means they don't necessarily mean you have CLL. If you have lumps and bumps, if you have B symptoms, that doesn't mean you have CLL. You could have a host of other things, but it could be CLL. So it's just something to consider. And unfortunately, a lot of these symptoms are so vague that your doctor may not know kind of what to make of it, because it's not really anything specific, but in the right context, it can mean something. And remember, again, I'll say again that most people actually don't have any symptoms. So often it's picked up just on blood work, which is why it is important to get sort of routine blood work once a year or so with your family doctor, just to kind of see that things are okay, especially above the age of 50 or so. So what tests do you do? So there was a question on this, and everyone, it was perfect, the answer. So a CBC stands for complete blood count, okay? And a CBC comes with a hemoglobin, a platelet count, and white blood cells, and it comes with all the different white blood cells. So if you want to know what someone's lymphocytes are, you get a CBC, and it will come with that. We also check the kidney and the liver because it can affect treatment, and I'll get into that later. We check immunoglobulins. Those are antibodies in your blood that help fight infection, and those can be low in CLL, so we check those. We do something called flow cytometry, which is a very special test. And we do it in very rare cases. We do it especially for diseases like CLL. What it is basically, it's a test that we put the blood through a machine that detects what antigens or what proteins are on the surface of the blood cell. So it's actually pretty cool because every little cell in your body goes through this machine one by one, and the machine can tell us exactly what proteins are on the surface of the cell. And why does that help us? Is because CLL has a very specific set of proteins on the surface. And when we can detect that, we can say, okay, this is CLL and not something else. We also do molecular or genetic testing. And I don't mean genetic testing like something you inherited from your parents or your grandparents. I mean specifically mutations or genetic aberrations in your body, that can help us determine the prognosis of CLL. And we'll get into that a bit more later as well. So you've come in, you have these symptoms, you got some tests done, your doctor has all this info, or your oncologist has all this info. So how do you diagnose CLL? How do I tell patients, okay, you do have CLL based on, X, Y, Z? So how I do it is basically, it's purely and most importantly based on the CBC and the flow cytometry. So on your CBC, you have a high lymphocyte count, and in your flow cytometry, the machine told us that this is CLL. So typically the lymphocyte count needs to be above 5 in the flow cytometry. So let's say you have a lymphocyte count of 10 in your blood. It might not actually be more than 5 on the flow cytometry, because not all of those are cancerous, right? So maybe only 3 or 4 are cancerous. And I don't mean 3 cells, it's a concentration. So 3 is more of a number to describe it. But my point is that the number of cancerous cells concentration needs to be above 5 on the flow cytometry reading to classify as CLL. So that's how we diagnose it, the CBC and the flow cytometry. We also do some other tests. It's not always needed. Number one, a CT scan. We do that if you have a lot of lumps or bumps in your body, and we want to see if there's lymph nodes that are swollen. Bone marrow biopsy is almost never done in CLL. You may have had one, and that doesn't mean it's wrong. It's just sometimes we do it if we still don't know what's going on, or if other blood counts are affected, or a variety of reasons. But you don't need it right off the bat for CLL. Lymph node biopsy is again, not very common, but we do it if you have big swollen lymph nodes and we want to know what's in there. Most of the time, we don't need to do a biopsy because we can figure it out just from flow cytometry of the blood. But sometimes it's, we don't have a good answer or whatever it may be. And so we do a lymph node biopsy as well. All right, so that's the diagnosis of CLL. Staging. So the biggest point here, what I want to point out is the staging of blood cancers is very different than when you're staging other cancers. So you or other family members or friends you may have heard of who have unfortunately had other types of cancers, you may have heard them talk about staging where, let's say we're talking about lung cancer. You have a mass in your lung, and then you do staging where you do CT scans, and there's also a mass in the colon, and then maybe there's a mass in the bone. So depending on where the cancer has spread, we can stage it. Blood cancers or lymph node cancers are different because by definition, they're already spread because everything's connected. Your blood is connected throughout your whole body. So it's not really staged in the same way because it is already spread right off the bat. Everything's connected, right? So the way we stage CLL is we go by the RAI staging system, RAI stage. And that just refers to the system that was discovered. They named it RAI based on where it was found. Stage 0 to stage 4. So stage 0 means all you have is a high lymphocyte count, and that's about it. Stage 1 is that you have enlarged lymph nodes along with the high lymphocytes. So it's kind of additive. Stage 2 is your spleen or liver are also enlarged. Stage 3 is that you now become anemic, which means your hemoglobin is low, less than 110. Normal is about 120 to 130. Stage 4 is low platelets. So your platelets are less than 100. So platelets are a type of blood cell that help with blood clotting, also comes with the CBC, and that would be stage 4. Please keep in mind, though, that this is not like other staging. So if you're a stage 4 because your platelets are low, it's not, something dangerous. It's treated the same way, honestly. And so it's not, this huge change in your prognosis, in your life and all of that, just because you're a stage 4. There are other things that determine prognosis, which we'll talk about. And certainly having a higher stage is a bit worse than lower, but I just want to point out it's not all that much worse because technically these stages are just kind of a mechanism to figure out where the disease is at. They're not necessarily like other cancers where it's spreading and then you go on higher stages. So it's a little bit different. So speaking of that, prognosis. So the word prognosis essentially means how bad or how good is your cancer, to put it bluntly. And there are so many factors that determine this, and they're not all equal, and they don't always all mean the same thing. So it's very complicated, but I'll give you a gist of it. The main the main indicator of prognosis is molecular and genetic testing. So when you're diagnosed with CLL, please talk to your oncologist and ask them about genetic or molecular testing if they haven't done it already. So in my practice, when I see my patients with CLL, I get some of these tests right off the bat, just so we know what's going on. Some people will get them done when you're starting treatment, and they won't do it in the watch and wait time. Some people, like myself, do them a bit earlier, just so we're on the ball a little bit. So there are some genetic mutations in your blood, which are called fancy names: 13q, trisomy 12, 17p. These mean basically the number is the chromosome. So everyone has 23 chromosomes, 46 because they're double, and an X and an Y chromosome. If you're male, XY, if you're female, XX. So we all know about that. But in those chromosomes, there's a P arm and a Q arm, each chromosome. And when I say 13q, trisomy 12, I'm referring to the chromosome and some sort of problem in that arm or some sort of issue with the chromosome. So a 17p deletion means part of your 17th chromosome P arm is deleted. And so these aberrations or mutations are seen in CLL, and some are good and some are bad and some are intermediate. So 13q, trisomy 12 are generally good prognosis or intermediate, which means your CLL is probably not going to affect you anytime soon. 17p is generally more of an aggressive CLL. So what that means is that, it doesn't mean that you're going to have bad disease right off the bat, but it does mean that down the road, as you get older and the years pass, you might start to see the CLL get a bit worse, maybe a bit faster than someone who has a 13q. There's also something called immunoglobulin heavy chain, IgHV. What this is it's another feature of the CLL. I won't get into details, but basically it's a protein on the surface of the cell, and it can either be mutated or non-mutated. Now, if it's not mutated, that's not a good prognosis. If it is mutated, it is a good prognosis. And again, it's like the 17p. It just means if it's not mutated, there's more of a chance that your disease could be a bit more aggressive than someone who it was mutated. So these tests, it's not really something you need to know or remember. It's complicated, but it's just something to know in your head that, okay, if I have CLL, there are genetic tests that can be done that can help my doctor determine prognosis and also treatment, because this will affect treatment as well. So just something to ask about and something to keep in mind. And I'm sure a lot of you have already had these tests done. If you haven't, it's something you could ask your oncologist to discuss with you whether you would be a good candidate for these tests. All right, so now we'll spend the next little bit until we finish off on the treatment. So when to treat CLL. So this is a huge area that people always ask me about, and a lot of my patients ask about this because they don't know when to be treated, or they don't know why they're not being treated, and it's all very scary, which is understandable. So in CLL, the biggest thing to know is that not everyone is treated. And it may sound counterintuitive as I have cancer, but I'm not being treated. That's okay, because actually CLL is not a kind of cancer that will affect you unless it does. So many people, it doesn't affect them at all until the day comes when it does. When it's not affecting you, we don't need to treat you, because believe it or not, the treatment will affect you more than the cancer itself. So we actually don't treat it unless we absolutely need to. And a lot of people ask, well, wouldn't it be too late by then? The answer is not really, no, because it's a very slow growing disease. And when it starts getting worse, we can detect that pretty quickly. It's rare that it would go from 0 to 100 overnight. It's very rare. I almost never see that. So most of the time we can get on it pretty quickly. But the point is, we don't treat it when it's sleeping and not affecting you, because you don't need treatment. You're fine the way it is. You don't need anything to make things worse. So when do you actually treat patients with CLL? So when do I treat patients? So number one, low blood count. So if you're starting to become anemic or thrombocytopenic, which means low hemoglobin, low platelets. If you're starting to have a lot of symptoms, so more than 10% of your weight loss over 6 months, fevers, night sweats, fatigue. If you're starting to have a big spleen or big lymph nodes that are sort of lumps and bumps in your body that are affecting you, then we would consider treating. If you're having any other symptoms, and then numbers, so we don't treat numbers. So there could be people out there who have a lymphocyte count of 200 and we're not treating them. There could be people with a lymphocyte count of 10 and we're treating them. So the number doesn't really matter, it's the trend. So if you're always at 200 and you're fine, that's fine, we don't need to treat you. But if you're usually at 20 and then now you're at 100 and then you're at 200, then that's more of an issue. So if I see doubling of lymphocyte counts in under 6 months, or a 50% increase in 2 months, then I'm more inclined to consider treatment. So I have patients that are at a lymphocyte count of about 30, 40. They've been there for years. One day they come to see me and it's 60. So then I'm considering, okay, this is odd, something's going on, we'll repeat it again. Then a couple weeks later, they're back down to 40. So that's okay, it goes up and down. Maybe you're a little bit sick, maybe you had an infection, something happened, it went up and down, that's fine. But let's say I see you again and now it's 70, and then it's 80, 90, then it goes to 100. Then you're thinking, okay, now we need to consider doing something about this. So it's really a flowing sort of monitoring process. It's not a decision made overnight. It requires a lot of monitoring and a lot of context. We don't go purely by numbers. You really have to put it into context. Similarly, a lot of people have weight loss. A lot of people have night sweats. That doesn't necessarily mean you need treatment. It's something to consider and something to put into context. But remember, it needs to be discussed with your doctor to determine finally what you do. And it really is a mutual discussion before you go on to treatment. So before we actually treat, there are some considerations that we take. So disease and patient. So I like to talk about it in two categories. What is the disease doing that will affect treatment, and what is the patient doing? So disease, we think about the molecular genetic testing and the symptoms. So do you have a 17p deletion? Do you have night sweats? What's going on there? Patient, we think about, do you have other medical problems? What's your functional status? So is it an elderly patient who isn't able to walk, is debilitated, has other medical issues? Or is it a younger patient who's very healthy and can tolerate more aggressive treatments? Preference. So preference is very important. I always talk to my patients about what they prefer, what medications, I give them the options and what sounds good to you. What do you think you could tolerate? You know your body better than anyone else. Drug coverage is what drugs are actually covered. So we can be amazing and say, I have all these great drugs available for you. You can do this, or this. But the reality is not all of those are covered by the government, unfortunately. And that's just part of our healthcare system, like it or not. Unfortunately, only certain drugs are covered. It's a financial issue at times. But they are very reasonable. If you need a drug, they generally would cover it. There are situations where they don't, and we have to go through other avenues, etc. But drug coverage is something we need to consider. These are very expensive drugs. This is not something you can afford out of pocket in most cases. But it's something we consider. So before we treat you, we would consider two things: the disease and the patient, which is you. All right, so treatment options. And I love this picture because it really is, CLL is all about this, is should I do this or this or this? And it's sometimes it's really difficult to make a decision. And the biggest decision is, should I treat or not, first of all? And if you decide to treat, then what are the options? What do I do? And there's never a right answer, and that's what makes it complicated. So number one, watch and wait. The most common treatment in CLL, and the one that most people like the most, including myself, just because everyone's happy, everyone's comfortable, everything's good. So no treatment unless you have a reason to. That's the goal of CLL. Do not treat patients with CLL unless you need to. So if you're being treated, there's a good reason. If you're not being treated, there's a good reason for that too. Watch and wait until reasons to treat. So I treat patients if they have symptoms, low blood counts, lymphocyte counts doubling, lymph node swelling. We talked about this already. This is just a recap. So that's your watch and wait piece. Next option, so chemotherapy and immunotherapy. So chemotherapy refers to basically medications that kill cancer cells. It's toxic, it can affect you. It sucks. Like, a lot of people don't like it. It's not something we want to do unless we have to. Immunotherapy, though, is not really chemotherapy. Immunotherapy is more of a biologic. So what that means is it affects very specific cells in your body. It doesn't just clean sweep, kill all the cells that it sees. It's very specific, and that's why we like it, and that's why we use that a lot these days. Chemotherapy is usually used in combination with immunotherapy in most cases, sometimes not, and we'll get into that. So chemotherapy is mainly used for overall fit patients. And when I say fit, I mean generally people who don't have a lot of medical issues, who are robust, functional, tend to be a bit younger, although a lot of elderly patients are very fit as well, which is excellent. I love seeing that because they're active and they're functional. One of the biggest chemo regimens we use in CLL is FCR. All chemotherapy is named by their initials or letters. So if you're getting fludarabine, cyclophosphamide, and rituximab, those names are way too long for anyone to pronounce. So we shorten them to FCR. Chlorambucil and obinutuzumab, that's another regimen that you may have heard of. Bendamustine and rituximab, that one's shortened to BR. BR is another chemo regimen that we use. So these are just big names, but basically all they mean are drugs that kill cancer cells, and we call them by their initials. So chemo, the mechanism is it kills cancer cells through various mechanisms, like I said, and immunotherapy, like I talked about, are very specific targets on certain cells. Side effects. So chemotherapy is a killer for side effects. We all hate them. Everyone is very unpleasant through this, and it's not great, but it's something we have to put up with for the chemo. So nausea, vomiting, very common. Drop in blood counts. So chemotherapy drops your blood counts, and so we have to monitor it. Infusion reaction. So when the chemo is going into your veins, you might get a reaction with it. Hair loss, as I'm sure a lot of you have heard of or maybe experienced. It can be very frustrating and very demoralizing to lose hair, and so we try to support people through that, etc. So there's a lot of side effects with chemo. Unfortunately, it's a double-edged sword, but it is a very good treatment option for any cancer, and including CLL. Next, so biologic therapy. So this is sort of our big new kid on the block, sort of very big new therapy that we love using. So ibrutinib or Imbruvica is something you all may have heard of, and a lot of you may be on this therapy. It's a pill, which is excellent because it's very convenient. It's basically a pill that targets an enzyme. An enzyme is a protein in your cells called BTK enzyme. BTK, or Bruton's tyrosine kinase, is what it's called. If you sheaf back to sort of your biology, maybe somewhere in university or high school, enzymes are proteins that help cells function, and the BTK helps cells grow. We don't want that to happen. We don't want your cancer cells to grow. So by killing or targeting the BTK enzyme, we stop the cells from growing, and so they die. And that's a good thing. We want the cancer cells to die. Another one similar to ibrutinib is something called idelalisib. This one targets the PI3K enzyme. So similar, but it's not BTK, it's a different one. Venetoclax is another one. It targets the BCL2 protein. So these are all similar drugs, but they affect different proteins, and the final result is the same: stop the cancer cell from growing. The side effects are very unique to each of these meds. I won't read them all. You can see them there on the slide, but basically I'll highlight ibrutinib. Some of the side effects are atrial fibrillation, which is an abnormal heart rhythm or palpitations. Bleeding, because it does affect your blood clotting, so you tend to bleed more. Nausea, vomiting, diarrhea, and fatigue, which is a very common side effect with a lot of these meds. I'll also highlight venetoclax is notorious for causing something called tumor lysis syndrome. And this is basically, so when you have a malignancy or a cancer and we start killing all your cancer cells, the cells release a lot of toxins. And these toxins can cause gout, they can cause other electrolyte abnormalities in your blood, and that's called tumor lysis syndrome. It's basically a problem when you lyse or kill cancer cells and they release all these bad substances into your blood. So we give you medication to prevent tumor lysis syndrome. Now, we'll cover this in drug coverage slide a little bit later on, but ibrutinib is not cheap. It's an expensive drug. It needs to be covered by the government. Or by, we often apply for compassionate coverage with the drug companies. It's covered generally if you have a 17p deletion, which, if you recall, is more of an aggressive CLL, so it makes sense that they cover this medication. Or if you have an unmutated immunoglobulin heavy chain, so IGHV. So I talked about these two things in my other slide with prognosis. Both these two things give you a bit of a more aggressive or a bit of a worse prognosis. So not something to really worry about. It's not a huge issue, but it is a bit worse than someone who doesn't have it. And in this case, this medication would be covered, the ibrutinib, for these two features of the disease. Stem cell transplant. So we're still going over our treatment options here. A stem cell transplant, I will mention, is very rarely done in CLL. I have maybe 1 or 2 patients that have had this. It's very, very, very rare. Not to say it's impossible. It's usually done when your CLL is coming back over and over again and not responding to any other therapies, including ibrutinib, maybe idelalisib, venetoclax. We try, but nothing's working, then we may consider a stem cell transplant. Other reasons is if you're young, very young, if you're in a clinical trial, if you have very high risk disease, or transformation. So what that means is CLL, and we'll talk about this in the complication slide, but CLL can transform or turn into a more aggressive disease called diffuse large B-cell lymphoma. It's a big word, but that's another type of lymphoma. It's much more aggressive than CLL, but CLL can actually turn into that. And if that happens, some of those people get stem cell transplants. A stem cell transplant, I'm not going to go into the details, but the gist of how it works is that they remove stem cells from the donor. Sometimes the donor is yourself. They remove it, and then they give you, the patient, high dose chemotherapy to wipe out your bone marrow and your cells. So essentially you have 0 blood cells. They wipe them all out, and then they give you the new stem cells that the person donated. It could be a spouse, or sorry, not a spouse, sorry, my mistake. It's usually a sibling. It's usually someone who is related to you. child, sibling, etc. Not a spouse. That was a mistake because your spouse typically wouldn't be a match, of course. But essentially, they put the new stem cells into you, and you now generate a new bone marrow. So that's what a stem cell transplant entails, and of course, it's done in very rare cases, as I said. And finally, CAR T therapy. So this is a very, very new therapy. There's a lot of research being done in this. I've had a couple of patients who have inquired about this. I haven't yet had a case successfully done with this yet because it's really quite rare. It's for very high risk, aggressive, relapsing CLL. Sometimes this is CLL that doesn't even respond to a stem cell transplant. It's really, really aggressive. So then they do CAR T therapy. CAR T therapy, there's some trials offered in Montreal, I believe, for this, and maybe even in downtown Toronto now. It's a very interesting and quite an advanced technique that's used. So what it is that they take the blood out of you, and then they reprogram your cells in your blood. They change the DNA, and then they put the cells back in, and they actually go and attack the cancer cells. So it's actually very unique. They make your own cells turn against the cancer cells in your body. So your body starts attacking the cancer cells. And that's actually genius because you're fighting the cancer yourself just because we've reprogrammed your cells to do that. So your body defends itself, which is really a great way to kill the cancer cells. And it's something that's really up and coming. Radiation is very, very uncommon again. It's typically done for very localized disease. So if you have SLL or CLL just in one area, like maybe just in your neck, one little lump in your neck or one bump in your neck, and it's very painful, then they may radiate just that area. And sometimes it's done for symptoms. So if you're having a lot of pain somewhere, it's just one area, they might radiate. It's uncommon. Usually I would do more medication treatment, but radiation is something we would consider in very select cases, a case-by-case basis. Clinical trials are very important. I mention this because when you're diagnosed with CLL as a patient, you should always ask your oncologist or your doctor about clinical trials, especially if you're in downtown Toronto, because there's a lot of trials going on right now that are trialing new therapies and new treatments. And if you're willing to, participate in those, it's very educative for us and for you, and it really helps us to decide whether these treatments are working or not. None of them are going to really be dreadfully harmful or anything. These are all drugs that have been trialed in earlier trials. Some people are always skeptical because they think, I don't want to be a guinea pig kind of thing. And you're not. I mean, really, it's a drug that has been trialed earlier, but now they're trialing it in more of a larger setting. It is your decision ultimately, but it is sometimes a great option because for people who don't respond to other medications, a clinical trial may actually give them a good response because these are new medications that tend to work quite well as well. So always ask about it. My patients ask sometimes, or I mention, and it's usually people who have not responded to other therapies, and I might refer them to downtown Toronto for a clinical trial. At my hospital, we have some trials going on as well, it may or may not be something you're interested in, so definitely ask about that. So that was pretty much the treatment aspect of things. So I'll do a quick summary and then we'll finish off with some information about side effects and such. So just to summarize again, watch and wait until you need to treat. If you have a molecular abnormality like the 17p or the unmutated IGHV, then we usually get ibrutinib. If you can't get ibrutinib because you don't have those features, if you're really fit, you could get actual chemo. If you're not so fit, we might have to give you a lower dose chemo or just supportive palliation, that kind of thing. So it really depends on the patient. The treatment duration, so the watch and wait is variable. You could be on a watch and wait for years and years. You could be on it for months. It really varies. The chemo is time limited. So if you're on chemo, it's typically going to be like 3 or 4 months and that's it, or longer, but it is limited. Biologic therapy is usually indefinite, which means if you're on ibrutinib, you're probably going to be on ibrutinib for life. Unless it stops working, then we may switch to something else, but you're probably always going to be on something. So how to minimize side effects? I won't read all of these. You can kind of browse through them, but basically we do a lot of things to prevent the side effects. We give medications for gout, we give medications for nausea, for reactions. We sometimes reduce the dose. We give you a lot of hydration, watch for interactions, check your kidney, your liver. So there's a lot of things that we as physicians can do. And I try to do all these things with my patients and really say, okay, what side effects are you having? How can we deal with those? How can we prevent those? And how can we minimize those side effects going forward? How do we check for response? So if I start ibrutinib on a patient, how do I know that they're getting better? Well, we check to see that their symptoms are better. It's as easy as that. We check that their blood counts are better. So if their lymphocytes were 300, we check that they're coming down. Check that they're not worsening. And we may do some CT scans or other imaging to make sure that things are better as well. Not always, but the gist of it is that we make sure you're getting better. That's really all there is to it. So complications of CLL. So when you have CLL, a lot of the time it's smooth and you're on treatment and things are getting better. That's the ideal situation. That's what we want. Sometimes you can develop other complications. So for example, hemolysis. So what that means is that your body is just destroying the red blood cells in your body. So it's going crazy and destroying all the red blood cells. It's not a great thing to happen, but we can treat it. It's something that can happen in CLL. It's treated with steroids, a steroid pill. ITP, it's called immune thrombocytopenia. That's the same as hemolysis, but it's your platelets. So your platelets are being destroyed, and it's also treated with steroids. You can get infections when you have CLL because, like I said, it does lower your immune system. And this is treated with antibiotics, or sometimes we give you antibodies, pardon me, and that helps you to boost your immune system. It can also transform to an aggressive lymphoma, like I talked about, and that's treated with chemotherapy. So these are all things that can happen as complications in someone with CLL. There are also treatment-related complications. So remember, treatment is always a double-edged sword. It's good, but it's also bad because it causes complications. So infection. I stress this because anyone on treatment, chemo, biologics, whatever it is always at a risk for infection because these treatments do affect your immune system. So I always tell patients, if you have a fever or an infection when you have CLL and you're on treatment, you should go to emergency to have that looked at, get antibiotics. Dropping blood counts. All treatments can drop your blood counts and you need monitoring. Tumor lysis, we talked about, it's when the cancer cells release those toxins and can cause gout. Nuisance side effects like nausea, vomiting, hair loss, we talked about that. And then treatment-specific effects, so things like the nausea, vomiting, and the bleeding with ibrutinib, like specific things like that. Drug coverage. So as I talked about, ibrutinib is covered if you have the 17p deletion or if you have the IGHV unmutated. It's also covered if you have relapse disease. So if you got chemo and then the CLL came back a few years later, you could get ibrutinib. If we cannot use ibrutinib, we'll try to use idelalisib or venetoclax. If you don't respond to ibrutinib, we sometimes do venetoclax, so that's like the next line. Chemo is often covered for most people, depending on previous use. So if you just had chemo, it may not be covered for the exact same chemo. You might have to do something different, but that depends. I want to just a shout out to the drug access coordinators in your hospital. So wherever you're being treated, we have an excellent drug access coordinator at my hospital. They help with this stuff. So as physicians, we don't always know what's covered and what's not because it's always changing with the government, right? We know what we'd like to use, but we don't always know if it's covered. So the drug access coordinator, it's their job to help you with this. What's covered, what's not, what can this patient get, what does your drug plan cover? So they will help you with this. So definitely ask to talk to the drug coordinator if you haven't already to see what you're eligible for. So treatments in the pipeline. So these are things that are up and coming. I didn't talk about this too much because we don't have a lot of data on this, but acalabrutinib is like a cousin to ibrutinib. It's more specific and it causes less side effects. So it's very, very attractive and we want to use it more, but we haven't yet used it that much because there's some issues with coverage, but it is coming. Revlimid is another medication used in another blood cancer called multiple myeloma, but it's showing some benefit in CLL as well. Alemtuzumab is usually used for T-cell cancers. So I told you there's B-cell and there's T-cell lymphocytes. CLL is B-cell, but there are some T-cell cancers that alemtuzumab is used for, but it seems to work for CLL as well. So it is coming. Venetoclax is being used more and more. and combinations are being used more. So combining like venetoclax and ibrutinib, or venetoclax and rituximab, like doing combo therapies, is becoming more common now. Most of you are probably only on one drug, like ibrutinib, venetoclax, just the one, but a lot of people now are on doubles, just because we're finding it tends to work better in people who don't respond to the singles. So patient support is very, very important. So as a physician, I can only do so much in terms of support. So I try my best to educate patients. I try to give them all the resources they need. But beyond that, you need to talk to the people who can really help. And so I always refer patients to reputed sources and people. So the Lymphoma Leukemia Society today, they have a lot of supports in place, a lot of that we talked about earlier in this presentation. Reputed online sources. So I'm sure you hear this all the time, but don't read about your cancer and your treatment on Google unless you're looking at a good website, Lymphoma Society, reputed sources. Like I'm struggling to think of a lot of them right now, but the societies, basically, online journals, that kind of thing. Off the top of my head, those are the things I could think about. But basically, just make sure you're reading a good website and not just anything, because sometimes it scares you and a lot of that information is out of context. The cancer care team is very important. At my clinic, I have nurses, I have dietitian, I have a drug access coordinator, I have the clerical staff that all work there. So they're all part of a team that help you in your cancer care journey, and they're all part of the process. And so it's important to recognize them too. The CCO, Cancer Care Ontario, that's the society that helps with a lot of the drug coverage issues. CLL Society, other patient support groups. So seek out whatever you need, but make sure that you have the support you need. If you feel that you're not eating very well, you'd like to have more nutrition in your disease and your diagnosis, talk to the dietitian. If there's issues with drug coverage, talk to the drug access coordinator. So definitely get the team involved, and your physician will help you do this, but it is very, very important to have that support group. All right, so to finish off, we'll go back to the questions that we talked about earlier and just kind of summarize where things are at, okay? All right, so which of these is false? All right, let's see. So this question, I think we, let me see here. We may not have actually had this. Yes, I'm sorry. This question actually we changed up a little bit, so which of these is false was the question. The one that you did was a little bit shortened, so I apologize for that, but the gist is the same. All patients diagnosed with CLL are immediately treated with either chemotherapy or biological therapy. I shortened it for the actual question, but that's the answer, is not all patients are immediately treated. As I talked about numerous times, that is false, and most people got that right. It's because a lot of people are on watch and wait. Which test is important for diagnosis? So CBC is the complete blood count. You absolutely need that because it tells you what your lymphocyte count is. Bone marrow biopsy, as I talked about, is not always done, not essential unless there's a reason. Flow cytometry is absolutely essential. You need that test done to diagnose CLL. PET scan, we don't do in CLL. Sometimes you might hear of it, but it generally does not help you in CLL. It's a scan where they inject a little bit of sugar in your blood and then it lights up wherever you have cancer. It's done for lymphoma. It's sometimes done for myeloma, other blood cancers, not typically done for CLL. So A and C would be the right answer. And that's basically because you need the CBC for the lymphocyte count and you need the flow cytometry to diagnose CLL. Which of the following is not a treatment option? So it is hormone therapy, as most people said. Chemotherapy, definitely an option. Bone marrow transplant, rare, but it is an option. Immunotherapy is definitely an option. Biologic therapy, which is similar to immunotherapy, definitely an option, like ibrutinib. Hormone therapy, such as estrogen therapy, etc., is not an option. It's used for breast cancer, used for other types of cancers, but not in blood cancers generally. Which of the following is a biologic therapy used in CLL? It is, of course, ibrutinib, very, very commonly used. Imatinib is used for CML, chronic myelogenous leukemia, which is another type of blood cancer. Revlimid is used in multiple myeloma. It can be used in CLL, but it's not that common right now. Chlorambucil is used in CLL. That's a bit of a trick, but it's not a biologic. It's full-blown chemotherapy. Which of the following is a known side effect of ibrutinib? So it is all of the above, as I talked about. So it can cause AFib, atrial fibrillation, irregular heart rhythm. It can cause bleeding issues more than usual, and it can cause nausea and vomiting. So it is all of the above. Thank you. So I think one of the things that everyone misses the most during COVID is travel. So here's a nice little picture of my travels in Venice before COVID, of course, to finish off. So thank you so much for staying and for listening. I hope that was helpful. And I guess we'll turn it over for questions to Sonia.
Thank you very much. That's a beautiful picture.
Thank you.
Looking forward to some traveling too. Yeah. So, yeah. Thank you so much for sharing your time and expertise today. That was really informative, a lot of great information, certainly helped me figure out a lot of things. So thank you very much. So it is now time for our question and answer period. And as I mentioned at the start of the presentation, I would invite you to ask your questions in the question box in your GoToWebinar panel. We did receive quite a few that came in throughout the whole presentation. And we also received a few before the presentation at the time of registration. So I'm gonna start reading out some questions. And I want to also remember, as I mentioned in the beginning, if we don't get to answer your question live today, we will do our best to follow up with you afterwards via email. We'll have our community services managers reach out to you. So obviously there's been a lot of questions about COVID and CLL. So I'm going to kind of combine all of those into one. So what are the risk factors for those who have CLL with COVID? Should CLL patients basically make sure that they have that they have virtual meetings instead of in person? And once the vaccine comes out, can they also have that vaccine?
Sure, yeah, so great question. And I apologize, I did want to put in some info about COVID right in the presentation because I know it is important, but I'll address that. So unfortunately, we don't have a lot of information yet about the vaccine. I'll start with that just because I know it's on everyone's minds. It's coming, but we won't know until we've actually given it to patients whether it affects you negatively in terms of CLL or not. I suspect probably if you have CLL, it should be fine to get the vaccine, just like the flu shot or anything else. It remains to be seen how effective it is, but I don't think there's going to be a problem with you getting it. I would say if you're actively on chemotherapy, they might recommend that you wait till you're off chemo, when you're in your break of chemo to get the vaccine. But again, I can't say for sure. That is kind of yet to be seen, but I think it will be a go. Like, I don't think you'll have to worry about getting the vaccine. In terms of other implications, so virtual is always better whenever you can. I'm seeing most of my patients virtually. I do see some in person if they're on active chemo or they have an issue that I really need to see them for. But if I can just talk to them on the phone about how they're doing or talk to their family member, especially if they're elderly, I would prefer that they don't come to the hospital, especially now. That might change, but I think virtual is always better if you can avoid going in. If your doctor wants you to come in for something, then I would, because I think that way they can assess and there's something they're worried about. But if not, then virtual is fine. If you have CLL, like I mentioned, you are a bit low on your immune system. Your immune system is not 100%, especially if your immunoglobulins are low. So you probably, or I shouldn't say probably, you are more at risk of infection than the general population. We don't have a number on that, but it is higher than the usual. So you do have to be extra careful with COVID precautions like washing hands, distancing, wearing masks, etc. So yes, you do have to be careful. And if you do get a fever or if you do think you have the symptoms of coronavirus, you should go to the hospital right away because you are at higher risk. But beyond that, we don't really know specifically how COVID affects CLL. If you got COVID and you have CLL, chances are it might be a bit harsher on you just because your immune system is not as good, but it may not. It's hard. Everyone's different, but there is a bit of a higher risk in that case. So I think those are the major things with COVID that we know. Beyond that, everyone's different. So it's really a case by case.
Thank you. What is the best way to manage side effects from ibrutinib? So like dry mouth, cracking, thinning fingernails, and so forth.
Yeah, so ibrutinib is one of those drugs. It's great, but it does cause some nuisance side effects. So the way I typically do it with my patients is that we talk about what exactly the side effect is. If it's something you can handle, then I usually say, let's just see how it goes. Let's try and ignore it because we do want you to get the benefit of the drug. If it's something severe, like a lot of bleeding, a lot of nausea, you're unable to function, the first step really would be to try and drop the dose a little bit. Most people start at 420 milligrams, but sometimes I go a little bit lower, 280, 140. Like there's different options we can sometimes do. So we try dropping the dose, provided that the CLL doesn't get worse. So it needs monitoring. Other things is dealing with the actual side effects. So taking anti-nauseant pills. For the bleeding, I encourage them to monitor it, avoid blood thinners unless you need it. For the atrial fibrillation, we may have to treat that with a heart medication or see a cardiologist. So we can treat each of those things, but I don't like when patients go on more and more medications, like more medications to treat side effects and then more medications to treat those side effects. Instead, we try and deal with the problem by adjusting the ibrutinib dose, but it's not always possible because sometimes the CLL takes a hit. So we really just have to monitor each person case by case. But those are the main things I would say that we do.
Thank you. There was also quite a few questions concerning extreme fatigue as a side effect. So one of the questions, which I think will answer majority of them, is why do I always feel so tired? I'm in remission, but I'm always so tired and there's no way to get out of bed sometimes. So how would someone handle that?
Yeah, so fatigue is a very, very common symptom, and unfortunately, it's very difficult to treat. It's not always from the CLL. That's the big thing to note. You should talk to your family doctor or your oncologist about other causes, like checking your thyroid, checking your other blood counts, checking your liver, kidneys, basic things to see there's not something else going on. But a lot of times, to be honest with you, it is just a consequence of having cancer. It makes your body tired. It's always trying to deal with this. It's tired, it's fatigued all the time. It can be from the medication, it can be from chemo that can last years. People who have stem cell transplants are fatigued for years and we just can't do anything about it. It's very unfortunate, but it is something that we struggle with. We do recommend a lot of relaxation techniques. Some people do yoga, some people do get massages, some people stress relieving activities. Those seem to help. As odd as that sounds, it is true. They do tend to help. Other things are, targeting what exactly is causing the fatigue. Like, are you not able to sleep? Is there stress in your life? And then talking about that and targeting that. Social workers are really important in this. So my point basically is that it's a very difficult thing to treat. It's not always the CLL, and when it is, it's difficult to get rid of because you're right, it's in remission, so there's nothing really to do there, but you're still fatigued, and it's probably the effect of the cancer or the treatment that you had months or years ago. So it's hard. I don't have a good answer, but you have to have a discussion with your doctor and come up with something that works for you.
Thank you. That's good advice. I have a few more questions here. So what can CLL patients who are on active monitoring can do to minimize or slow down the progression?
Yeah, so that's a good question. Unfortunately, not too much. Your body will progress when it wants to, unfortunately, and that's really how it is. And it's unfortunate, but there's no way for us to predict when that's going to happen and what you can do to stop it. Having those mutations I mentioned makes it more likely to progress, but nothing really you can do other than have it monitored. So your oncologist will see you probably every few months to check your blood. Monitor for symptoms. So if you're having new symptoms, fevers, weight loss, night sweats, lumps or bumps, then notify your doctor. That's really all you can do, is to be educated and cautious and aware of what's going on in your body. But beyond that, there's really nothing you can do to specifically slow it down other than have it monitored. Really nothing you can eat. A lot of people ask about diet, physical activity. That's all very important for general well-being, but there's nothing that has been proven to slow down the progression really, other than treatment if you need it, or just monitoring regularly. So that's the most important aspect of things.
Thank you. What tests should be requested to check if the spleen or liver is enlarged?
Yeah, so that's usually a CT scan. Sometimes we do an abdominal ultrasound. An ultrasound is a less invasive test. It doesn't include radiation, which is sometimes attractive, especially for younger patients. But if if they really want to get a good look, I usually do a CT, and I do of the neck, chest, abdomen, and pelvis, so your whole body, to kind of check for lymph nodes and large spleen. So the CT is usually the go-to, but again, discuss that with your oncologist, but that's generally the test that we do.
Excellent. We have time for 2 more questions. So this one here, why is the TP53 mutational test not done as standard of care? Oh, I think we might have a bit of internet issues. Dr. Bharath, can you hear me? Just give him a few more seconds. Maybe we'll see what's going on. Dr. Bharath? Okay, I think we might have had some technical issues. So yeah, he's currently offline. It might have just been something on his end. So unfortunately, I will cut this presentation a little short. However, please don't forget that all those whose questions have not been asked, we will do our best to follow up with you via email afterwards. So unfortunately, Dr. Bharath isn't online right now. However, I do want to thank him very much for helping us out today and for presenting such amazing information. I want to thank everyone who participated and who asked questions and who were here listening. So thank you very much for being here. It was very much appreciated. This topic is really important, so we are very happy to be able to do that. If you give me a second, I'm going to try and maybe share the slide deck at the end, so I can actually show you guys a few pieces of really important information. So if you can bear with me a moment. Oh, I think Dr. Bharath might have logged back in, actually. Dr. Bharath, are you still there? Okay, I'll just share my screen. That's okay. Here we go. Okay, so audience view. There we go. I apologize for the small little technical difficulties, so just give me a few moments. There we go. I'd just like to jump to the end of our presentation. Dr. Bharath, if ever you are there, please feel free to just jump right in. Right. Okay, so I'd like to thank our marquee sponsor, Astellas. I'd also like to thank our other sponsors, AbbVie, AstraZeneca, Bristol Myers Squibb, Celgene, Janssen, Jazz Pharmaceuticals, Novartis, Paladin, and Pfizer. And I'd like to remind everyone that we are definitely here to help you. You can just simply pick up the phone and give us a call. We are here to help. Our phone number toll free is 1-833-222-4884. You can also send us an email at canadainfo@lls.org. Before I sign off, I'd just like to remind everyone that a short survey will be sent out to everyone. So please take the time to fill it in, as it will really help us to offer you the most valuable information and presentations in the near future. It would be really greatly appreciated. So I want to thank Dr. Bharath. I'd like to thank everyone who participated today, and I wish you all a wonderful day. Thank you so much.